He's getting lazy. But today we have Ryan Murphy, who's a senior fellow, home critical care, UW. He works with Teal in his lab, and he's going to be talking to us about airway hyperresponsiveness, clinical pearls, and insights into asthma pathogenesis. So thanks for doing this, Ryan.
Great. Thanks so much, Drew. Appreciate the warm introduction, and thanks for having me here today to chat. So I was looking back at the most recent content that's been in this lecture series, and there's, understandably within the allergy and immunology community been a focus on understanding the underlying mechanisms responsible for airway inflammation and asthma, and then kind of the more specific applications to understanding those biological mechanisms and using those to develop treatment algorithms for severe persistent asthma. And although that's something I'm certainly quite interested in, I figured today we might do just a slight shift in our focus to look at asthma physiology, and specifically looking at airway hyperresponsiveness. And I think the goal for this talk is, twofold. One, to provide a little bit of background on AHR, why it's important in asthma, what are some potential clinical pearls for use of diagnostic testing related to airway hyperresponsiveness, and then focus on a little bit of research that I've briefly dipped my toe into, but Teal has spent a career looking at, is the role of a specific form of airway hyperresponsiveness and how this might provide some insights into asthma pathogenesis. The goal for the talk is one, certainly to keep it relatively short and sweet. We'll try to get you out of here somewhere 7:45 to 7:50, or at minimum allow for time for a lot of questions. I have the chat box opened up, so if people have questions, feel free to throw them in there. If questions or comments come up through the talk, feel free to actually just shout them out. I'm fine with that. And I don't pretend for a second to be the expert of experts in this area, but I'll do my best to answer any questions. And with that, I guess I'll take it away. If I can, there we go. I don't have anything to disclose. And I think what we'll end up doing through this, we'll kind of keep this grounded in a few clinical cases that we'll come back to throughout the talk. In this first case is the case of a younger woman who's got some nonspecific respiratory symptoms and has had those for the past couple of years. And her symptoms got a little bit worse following an upper respiratory tract 6 months ago. She's currently having symptoms. Her primary care doctor diagnosed her with asthma, and she started on albuterol, and this might be helping her out a little bit. And then on review of systems, she's got some background chronic sinus symptoms that have been kind of ongoing for some time. She's had some diagnostic testing, including normal pulmonary function testing, a normal chest radiograph. And this will be the same two questions for all three of these patients: is, does this patient have a diagnosis of asthma? And if so, should we treat empirically? If not, is there more diagnostic evaluation we should do? And what tests should those be? The second patient, this is a 45-year-old woman referred for severe uncontrolled asthma. And hopefully some of these referrals are probably ringing a bell for all the clinicians here. These are actually three patients of mine. They're more or less an amalgam of patients that I follow, and I actually saw almost identical these three patients in one day about a month ago. She has kind of the classic symptomatology associated with asthma, with symptoms presenting as an adult. And then she's been to the ED several times in the past few months for acute decline in her symptoms. She seemed to get better with oral steroids. She does have some additional comorbid conditions, including obesity, reflux disease, and sleep apnea. And then she's on a understandably pretty aggressive controller regimen, including triple inhaler therapy with a high dose inhaled corticosteroid and a leukotriene receptor antagonist. She's also had lung function testing performed, which was normal, a chest radiograph that was normal, and the same two questions. And lastly, this is a young man who's got exercise-related respiratory symptoms, and he's a college track athlete. And he also had a prior history of chronic respiratory symptoms as a child, for which he was on and off albuterol, but was never formally diagnosed with asthma. But these symptoms seem to resolve in mid-adolescence and high school, and then have only recently returned. He also had normal pulmonary function testing, a normal chest radiograph, and then actually prior to arrival in our clinic, actually had a methacholine challenge test performed, and that was negative. And I think still the same two questions: how can you have a negative methacholine challenge test and potentially have a diagnosis of asthma, or is it effectively ruled out for this patient? And if so, or if not, how should we proceed? So kind of the outline for the talk. First, I wanted to just touch on some basics of airway hyperresponsiveness, defining it and then relating its importance to asthma, and then focusing on the two specific subtypes of asthma, direct versus indirect, and we'll talk more about that. Then we'll try to apply some of these AHR principles to clinical testing and hopefully provide some clinical pearls for the group. And then lastly, we'll push into talking about some basic science research, basic science and translational research I've been involved in, looking at insights into asthma pathogenesis. So we'll start with some basics. So what is AHR? So the definitions, and this is taken from the 2017 direct AHR guidelines published here in ERJ by Coates and colleagues. And this is defined as an increased sensitivity or exaggerated response to a stimulus that causes airway narrowing. And so the classic test that we all think of with airway hyperresponsiveness, of course, is Methacholine challenge testing. And so this graph here is probably familiar to a lot of folks. On the x-axis here is escalating doses of methacholine in a log scale. The y-axis here is the forced expiratory volume in 1 second, or FEV1, as a percentage of someone's baseline lung function. And you can see in patients who have asthma with relatively lower doses of methacholine, you get this sharp decline in FEV1. Again, the stimulus has caused airway narrowing. But you compare that response to a healthy control, where it takes quite a bit higher dose of methacholine to initiate airway narrowing. And so this patient with asthma has this increased sensitivity or exaggerated response that otherwise isn't seen in a healthy control population. And so why do we actually care about AHR? And to me, I think AHR is really a cardinal feature of asthma. It's a key driver of asthma symptomatology, and particularly plays a key role in driving symptoms in patients who have mild to moderate disease. We do, of course, spend a lot of our time wondering about biologic mechanisms and phenotyping patients with severe persistent asthma. And we spend a lot of our time and effort in that realm. But again, the largest bucket of patients with asthma have this mild to moderate severity phenotype. AHR itself is associated with a decline in lung function in patients with any obstructive lung disease. So if you have a positive methacholine challenge test or an exercise challenge test, that's associated with declining lung function regardless of your diagnosis. And also both direct testing, and we'll talk about that, methacholine challenge testing, indirect testing with exercise challenge or one of the other tests, is associated with development in asthma, both as children and as adults. And we'll talk more about that. And then lastly here, the severity of AHR is associated with frequency of asthma exacerbations. So basically the more sensitive or the more exaggerated the response you have to these stimuli, the more likely you are to have exacerbations and require escalated treatment. But overall, I think the biggest reason that people are interested in AHR and care about AHR is that we have diagnostic tests that can look for AHR, and they have a role in diagnosing asthma. But I'll put heavy emphasis on the can be helpful in diagnosing asthma. There are several caveats that I think we need to consider. So airway hyperresponsiveness comes in two flavors, direct and indirect. And I think these terms can seem sometimes a little bit nebulous, that they're relatively non-specific and thus hard to pin down and convert to kind of understanding. So they often get mixed up. First, we'll focus on direct AHR. So direct AHR is meaning an exogenous agent is something external is introduced to the airway. And then that agent acts directly to cause airway smooth muscle contraction or bronchoconstriction. It does act directly on airway smooth muscle, but it can also act through airway sensory nerves. And this, of course, is one of the key mechanisms of methacholine and histamine being really the only two direct AHR tests that we have. Methacholine, of course, being the more standard, commonly used study. Histamine, airway hyperresponsiveness, less commonly used. And these studies are graded dose response challenges, meaning that you're starting at a very low dose, it's giving serially higher doses as you go along. And in this way, the test is actually more controlled and it's more predictable. So you can take patients comfortably who have an FEV1 of 60 to 65% of the population and safely administer methacholine in extremely low doses, knowing that you're not going to tip them over to drop their FEV1, say, by 50% with the lowest dose. We'll compare that to some of the other indirect tests that actually give a single maximal dose that can drop the FEV1 quite quickly. And classically, direct testing is thought to be the sensitive test, right? This is the diagnostic study that can effectively rule out a diagnosis of asthma. But it in and of itself is not at the same time specific for asthma, and that's because there's several false positives. And this has to do with the mechanism by which methacholine and histamine cause airway hyperresponsiveness, and how we kind of report the results. So any airways disease, and COPD and bronchiectasis being two among them, are two diseases where there's significant alterations in the geometry of the airways, and also effective changes in the parenchyma of the lung. In COPD, there's a reduced effort of tethering of the airways open, and thus the airways are slightly floppier and they're more sensitive to mild changes and bronchoconstriction result in significant drops in FEV1. So COPD is a false positive. Similarly, bronchiectasis has several changes in airway geometry that can result in a false positive test. And then lastly, we'll spend time talking about healthy asymptomatic controls later on in the talk, but they also can be false positives. But of course, this is not a diagnostic study. We should really be obtaining in people who are healthy and asymptomatic. It doesn't really have a role there. In contrast, indirect airway hyperresponsiveness testing is where you apply some stimulus, and this stimulus itself promotes release of endogenous mediators within the airway. And then it's these endogenous mediators acting through similar mechanisms to direct AHR, through airway nerves and direct airway smooth muscle interactions that causes airway narrowing. And there are several types of stimuli, and they vary by the type of exposure and then also the dose. We'll talk about that difference between a maximal challenge with a single dose and then a graded challenge with an escalating dose. And indirect AHR is really thought to be specific, but not sensitive for asthma. It's estimated somewhere between 30 to 50% of patients with asthma will have indirect airway hyperresponsiveness. And there really aren't other disease processes that result in indirect AHR other than asthma, and that's why there's the high degree of specificity. And this is the form of AHR that's associated with asthma development in children who are asymptomatic. So in some of these birth cohort studies, they've looked at indirect AHR in childhood and then tracked these children later in life and found that it's highly predictive for development of asthma. And so in that sense, it's a nice potentially window into the research realm of kind of the underpinnings and early onset mechanisms of asthma. And so there's a variety of stimuli that can trigger indirect AHR. And the two most common tests far and away are the maximal challenge tests. And these involve, we'll talk about the mechanisms here in a second, but they involve basically breathing large volumes of dry air that ends up putting osmotic stress on the airway epithelium and then precipitates release of these mediators. And the two most common are exercise challenge, putting somebody on an exercise bike or a treadmill, getting them up to 85% of their maximum heart rate quite quickly, and getting their minute ventilation up to 60% of their maximum voluntary ventilation. And eucapnic voluntary hyperpnea, where you basically give somebody dry air, it's basically 5% CO2, and have them breathe it at 85% of their maximum voluntary ventilation for an extended period of time, and then measure spirometry after that exposure. This is in contrast to some of the graded tests that are less commonly used, and basically where you can do the same thing as methacholine or histamine, escalating doses. And hyperosmolar substances are something that are more frequently used. And mannitol and hypertonic saline are the most common of them. Allergen exposure is something that can also be done. It's something not done as routinely, more done in a research realm nowadays, but can be something that's applied in kind of a graded dose exposure. And then adenosine itself actually can trigger bronchoconstriction. But again, not something that's routinely done in clinical practice. Far and away, the common tests are exercise challenge testing and eucapnic voluntary hyperpnea. And how do these fit together? This is a nice figure I stole from Thiel's 2018 indirect bronchopropagation guidelines. and trying to form or put together how to connect the mechanisms responsible for direct and indirect AHR. And so I think initially that, methacholine and histamine function more downstream and act directly on bronchial smooth muscle or on airway sensory nerves that then trigger bronchial smooth muscle. And you contrast this with the other stimuli that can trigger indirect airway hyperresponsiveness. They seem to work more upstream, and they have impacts on the epithelium and submucosa and some of the other inflammatory cell types that are present in these tissues that then promote mediator release and then subsequently will precipitate bronchoconstriction. The mechanism by which exercise, eucapic voluntary hyperpnea, as well as hypertonic aerosols, how they end up generating osmotic stress is really by dehydration of the epithelium, and that triggers activation in the epithelium. Allergen-specific IgE exposures, again, different mechanistically, but will often trigger the same type of release of mediators. So here's kind of our break point between the two. So to summarize, direct airway hyperresponsiveness, again, acts directly on the smooth muscle or on the airway smooth muscle bundle, including the airway sensory nerves, and is a sensitive test for asthma. Contrasting that with indirect AHR, some stimulus generates a release of these endogenous mediators. It is not a sensitive test for asthma, but can be quite specific. Let me pause there if there are any questions that people have here. They want to throw them in the chat or just shout them out. And okay, if there are no questions, I'll keep rolling, keep throwing stuff out there if questions do come up. So let's try to apply some of these principles. So back to the first patient, a quick reminder, we'll talk about patient 1 and patient 2 first. So younger woman, non-specific respiratory symptoms, got started on albuterol for maybe asthma, has normal diagnostic testing. And the question is, does this patient already have a diagnosis of asthma? Should we just start her on empiric controller therapy? What are the next diagnostic steps? And contrasting that with patient 2, this is a patient who's got severe uncontrolled asthma with classic symptoms, but is on, has several comorbid conditions, and as of yet has not demonstrated variable expiratory flow limitation on her spirometry or other diagnostic testing. So potentially hasn't confirmed the diagnosis, although is being treated aggressively for asthma. And I think the reason that these questions end up kind of coming up so frequently at the end of these cases is that asthma is a challenging clinical syndrome to diagnose. And again, it's a syndrome that's supported by a classic clinical history and then some objective evidence of variable expiratory flow limitation. And really requires, it's really that second part, that objective measure that is often lacking in a lot of patients and sometimes can just be challenging to obtain. But we don't always try as hard, I think, as we should to sometimes obtain that more objective measurement. And this was a study, and there have been several like them by Aaron and colleagues. They took 700 patients in Canada who had a physician diagnosis of asthma within the last 5 years, and then did chart reviews on them and found that half of them actually never got a diagnostic study for asthma, and that included something as simple as spirometry or even peak expiratory flow rate meter monitoring. And then when they took these patients over the course of the next year and then intensively studied them for features of asthma, they found that a third of them actually didn't have a diagnosis of asthma at all. And the problem with that, I think, is that when they look deeper at this 1/3 of patients who were misdiagnosed, several of them had actually other serious medical comorbid conditions contributing to their symptoms, and several had coronary disease. One patient had sarcoid, another patient had bronchiectasis. These were disease processes that would have mandated additional specific therapeutics rather than inhaled corticosteroid and bronchodilators. And so in this sense, testing for AHR can potentially be helpful diagnostically in confirming the presence of variable expiratory flow limitation. But I think the more challenging part of this is identifying the patients that we should test and finding out which diagnostic test is best to order. And so direct AHR testing, and we had mentioned this up front, is really the sensitive study. And sensitive, again, just to be as explicit as possible, is a diagnostic study really to exclude a diagnosis, in this case, exclude a diagnosis of asthma. But thinking more generally and more broadly about diagnostic tests, that the specificity and sensitivity of any test really depends upon the patient population that you're testing. And in here, we'll talk about the differences between testing patients who are symptomatic versus asymptomatic, and the differences between testing a general population who's asymptomatic and don't have any risk factors for asthma versus a clinically symptomatic population. And then again, some of these things are quite simple, but I think important to remember that, you know, a diagnostic study's true value is to take your pretest probability, apply the test, and then get the result of that test and have that either positively or negatively affect your post-test probability to make a diagnosis more or less likely. And then finally, and this is a little bit specific to asthma, is that asthma itself is a dynamic disease, right? There are fluctuations in clinical symptomatology for patients with asthma, likely related to ongoing modulation in the degree of airway inflammation that's present. And this really means that airway hyperresponsiveness as a corollary is a dynamic clinical variable. And there are some patients who will have underlying asthma who will have quiescent disease. And thus, if they're exposed to methacholine, may actually not respond because their asthma at that time, they don't have significant lower airway inflammation at the moment that you're testing. And so AHR itself and some of these measurements will vary with the timing of which you perform the study. And so, I think the direct AHR testing and methacholine challenges will be kind of the one that we focus on the most here. I think the role of this test, again, is a sensitive test to rule out a diagnosis of asthma. And so, but we need to want to maintain the highest sensitivity possible and the highest diagnostic yield possible. We really need to apply it in the right way. And the best way to apply this, I think, is in patients who have a moderate pretest probability. We'll kind of walk through this graphic over here on the right. This is something I adapted from the 2017 bronchoprovocation guidelines. And this in and of itself, these curves that are present here represent kind of an idealized version of a study of different responses to methacholine and how this might change your post-test, compare your pretest to your post-test probability based on the result of a methacholine challenge test. And in and of itself is not representative of the study itself. It's a little bit more an idealized version of what the curves could look like. And so what you'll see here is different doses of methacholine PD20. So that's the provocative dose to reduce the FEV1 by 20% after exposure to methacholine. 25 micrograms being a lowest dose, meaning that there's high sensitivity to methacholine, 400 micrograms being the highest dose, meaning the lowest sensitivity to methacholine. And so if we take patients with this moderate pretest probability, and again, we're hoping to do this study to exclude a diagnosis of asthma. And so if we get a result where the test is exceedingly negative, that even at 400 micrograms, there is no drop in the FEV1, this results in, at the low end range, a 30% pretest probability drops to less than 10%, and a 70% pretest probability drops to less than 30%. You compare this instead to somebody who you think, 90 to 100% chance that they have asthma. Again, the test is not as helpful if it comes back negative because there's still a greater than 50% post-test probability that this is the diagnosis. And similarly, if you were to look at somebody who's got a 10% chance of having asthma, again, your post-test probability doesn't change that dramatically. It becomes less likely, but the absolute amount of change, you still think that there's a low probability that asthma is the correct diagnosis. You really want to perform this test on patients who are currently symptomatic. And this is a study that was done by Don Cockcroft and colleagues. He's been a researcher in this area for many years. And he looked at, this is a patient population of college or students, or basically young adults between the ages of 20 and 29. And he exposed them to histamine as the direct AHR test. And a histamine provocative concentration of to drop less than 20, the PC20 of 8 mg per deciliter. That's somewhere around a similar cut point to the methacholine PC20 of 8 milligrams per milliliter. And what he did is he looked at, of the patients in his study who were asthmatic, there was a significant difference in the response to histamine, whether or not you were currently symptomatic, meaning symptoms in the past week, or didn't have current symptoms. So all 17 of the patients with a diagnosis of asthma who were symptomatic had a positive response to histamine. But if you were not symptomatic, there were only 8 of the 35 who ended up having a positive response to histamine. And so I think you can take this 2 ways in terms of, sensitivity. There was no patients who are currently symptomatic with a diagnosis of asthma who tested negative via histamine exposure. And so the sensitivity in this case is excellent because you had no false negative tests. Compare that to patients who are currently asymptomatic, meaning not within the past week. A large proportion of them, 27 of the 35, over 75% of them, had a negative test, and thus would have been classified potentially as not having asthma, but that would be the incorrect diagnosis. And lastly, we talked about, mentioning healthy controls. He did this test on about 290 healthy controls and found that about 4.5% of them actually met the criteria for having a positive response to histamine. So again, this is not a specific study, meaning if the test comes back positive, that it confirms the diagnosis of asthma. It's not a diagnostic study that should be performed in asymptomatic healthy control populations. And lastly, you would prefer the patient not be on controller therapy. And this study has been done many times over the years. This was just one example by Okonkwo and colleagues that was published in 2019 that I thought was interesting. It looked at really the incredible sensitivity that AHR can have to just low doses of inhaled corticosteroids. And so what you have here on the x-axis here is the total number of doses of either a placebo or daily administration of 100 micrograms of fluticasone furoate. And on the y-axis here is the methacholine provocative dose to reduce the FEV1 by 20%. And this is measured in dose shifts. So for instance, say the first dose was 4 micrograms, the next dose 8 micrograms, 16 micrograms, and they double like that. So the dose shift would be a doubling effect. And with even a single dose of a low dose inhaled corticosteroid amongst these 11 patients who were studied, there was already a significant doubling in the methacholine PD20. In fact, one of these patients actually had a 2.3-fold doubling of the methacholine PD20 outside of the range that would be considered a positive methacholine challenge result, and thus would not have been diagnosed as asthma, as having direct AHR on the study. They then actually did a washout period for 2 weeks and then had the same 11 patients get placebo administration. And again, you'll see that there's more stability in the methacholine PD20 for patients who are not getting treated. So similar studies have been done on patients on moderate to high dose inhaled corticosteroids, also with leukotriene receptor antagonists that have found similar things, that you would really prefer your patients not to be on controller therapy when you obtain this diagnostic study. So our first patient, again, this is the younger one with non-specific symptoms. I'd say she's got a lower to moderate pretest probability for having asthma. She is currently symptomatic and she's not on therapy. And I did order a methacholine challenge test for her, and it came back with methacholine challenge PD20 greater than 400 micrograms. So again, not showing direct AHR. And I think she is a patient who's an idealized version of the right patient to test, that I can trust that this is a sensitive study and she doesn't have asthma. And that ended up being true. She didn't have asthma. We did some allergen-specific IgE testing, and she had some very mild allergic rhinitis that cleared up with appropriate management. And then her exertional dyspnea, which was still relatively profound, actually took quite a bit more digging and was actually found to have, on tilt table testing, postural orthostatic tachycardia syndrome, or POTS. And she's currently getting management for that and feeling better. And I think the key thing that this highlights, it's so easy to just start this patient on the ICS-LABA PRN and just say, well, it's probably asthma, just see if you get better, rather than digging deeper and getting a diagnostic study. In this case, it was extremely helpful because it made me kind of peel back some more of the layers and really search and find a diagnosis for her. The second patient, right, a 45-year-old woman who's got the classic symptomatology but hasn't met the objective criteria for airflow obstruction yet. And I'd say she's actually on the higher end, moderate to high pretest probability. And she's already receiving multiple controller therapies, including the high-dose ICS. And she actually saw a colleague of mine who ordered a methacholine challenge test while she was on these therapies, and it came back with no evidence of direct AHR. And the patient was told that she did not have a diagnosis of asthma. I saw her actually in follow-up several weeks later when she was having an acute exacerbation. It was an acute care visit, and we did spirometry on her, and she had reversible obstruction on that study. So she actually did carry a diagnosis of asthma. And the methacholine challenge test was a false negative, likely because of her being on controller therapy. And so, kind of to summarize here, my approach to direct AHR testing and methacholine challenge testing is that really the purpose of the study should be to exclude a diagnosis of asthma. And you want to perform the test ideally in patients with a lower to moderate pretest probability for having asthma, who are currently having symptoms and can be either they haven't been started on controller therapy and you're doing this early in the diagnostic evaluation, or you can safely wean them off their therapy for several weeks before ordering the study. And then, so lastly, this third patient, the track athlete who's got the classic symptoms of exercise-induced asthma, who's also not on controller therapy, and then had a methacholine challenge test that was negative. And again, he was told that he did not have asthma and thus didn't need treatment. And so again, looking at our kind of algorithm here, the ideal setting over here on the left, and in this patient, the test was really performed not to rule out a diagnosis of asthma. It was really done to confirm the presence of variable expiratory airflow obstruction. And I don't think that that's really the right reason, right? This isn't a specific test in any way. The pretest probability for this patient was extremely high. His symptoms were quite classic for asthma. There weren't many other diagnoses that we were considering. And so I don't actually think that methacholine challenge was the right study for this patient. And that gets into some of these false negatives that can occur with direct AHR testing. We talked about this again, asymptomatic patients who are currently on controller therapy, including those who are on their background bronchodilators at the time of the examination. Our respiratory therapists and people who set up our PFT labs are wonderfully knowledgeable in this, of telling patients if they're on rescue inhalers to be off of them for a specific number of hours prior to coming for the exam. And again, preferable if patients are not on controlled therapy at all. And then lastly, this is kind of a strange group, but elite athletes themselves who have exercise-induced bronchoconstriction and thus indirect AHR, they have a high frequency of having false negative testing. And in one study, and this is the study by Hallstrand and colleagues, published in JACI in 2002, looked at track athletes, 52 or 54 of them, around the time of the Sydney Olympics. And then about half of them ended up had a diagnosis of asthma. But of those patients who had asthma, only 9 of them had a positive methacholine challenge test. And when they exposed them and did indirect AHR testing, 25 of them had evidence of indirect AHR. So elite athletes, for whatever reason, probably the mechanism of their disease process is slightly more upstream. We'll talk a little bit more about that and what's specific about them. But I think elite athletes are ones that you might consider not performing methacholine challenge tests in. One, because of the high pretest probability, and 2, because they have a reasonable probability of having negative testing.
And are they ruled out for BCD?
The patients in this study, so I will tell you a lot of these studies that we're talking about. And so I'm talking about vocal cord dysfunction or variable inducible laryngeal obstruction. No, I don't think that they were these patients. Of course, there is an incredibly high overlap of VILO, VCD in this patient population, elite athletes and patients with asthma in general, but no, they were not. But of course, that might be a key caveat because of course that will affect airflow rates regardless of where the obstruction is. And similarly, several of these studies have issues. Going back even just for a second here to this study by Cockcroft and colleagues, many of the patients, about 100 of the patients in the studies were current active smokers. The diagnosis for asthma, I will tell you, was not the most rock solid. I mean, was there a physician diagnosis at any time? And we've already seen that physician diagnoses aren't always accurate because oftentimes they're made on clinical gestalt without the objective airflow obstruction criteria. Thank you for that question. So then what's the right test for this patient? And so I ended up sending this patient for a exercise challenge test. And I think just to be a little more explicit about it, this is what a figure Teal had sent me. I think when people think of exercise challenge testing, they often think of a cardiopulmonary exercise test. And that's something we certainly do in pulmonary medicine, and also the cardiologist will do as well. But that's not what an exercise challenge test is. A cardiopulmonary exercise test is there's kind of this graded ramp up in terms of the amount of work somebody has to pedal against on a bicycle ergometer, or be on a treadmill itself. This is different. There is no ramp up period when you're doing exercise challenge testing. You try to get people to maximum exertion over a very short window and keep them there for 6 minutes. And it's really that intense initial exposure that ends up precipitating indirect AHR. And so you'll measure a baseline spirometry on these patients. Often early in exercise, you'll get an improvement in someone's FEV1. And then for patients who have EIB, at the end of exercise, at the end of the 6 minutes, they can have quite significant, profound drops in their FEV1. And a positive test is defined, depends on the study you look at. A 10% decline in FEV1 or a 15% decline in FEV1 are the two most common thresholds. And one of the things that's interesting, and what we found, or at least what I found looking at some of the patients' TEALs studied over the years, is that patients with incredibly mild disease, mild intermittent asthma, who are not on controller therapy, that are rarely, if ever, using albuterol outside of the times that they're exercising, can still have profound drops in their FEV1 with exercise exposure, sometimes as much as 50% or more. And that's why you have to be cautious in these patients in selecting patients with really high and near normal lung function. Their baseline FEV1 should be above 75% predicted if you're going to order this study. And what you'll do, of course, is get serial spirometry following conclusion of exercise, and then at the end can give them bronchodilators to prove the diagnosis. So this patient did actually have a positive exercise challenge test, which was indicative of exercise-induced bronchoconstriction. He was treated with a leukotriene receptor antagonist and actually responded quite well, and eventually did end up developing more of the classic symptomatology of asthma outside of the exercise realm. But again, would have been labeled as somebody without asthma based on the methacholine challenge test result. So I think to summarize where we're at so far in terms of the kind of clinical pearls, before we talk a little bit more about that basic and translational science, is that AHR is really a cardinal feature of asthma. It does have an important role for diagnosing asthma, testing for AHR, but it does have some key caveats. And we talked about the differences between direct and indirect AHR. And thinking of direct, methacholine challenge test is far and away going to be the most common diagnostic study ordered. And it is the sensitive of the two studies. But again, it has to be, it's most sensitive really in the right patient population. And I think before considering obtaining the test, you really need to recognize the potential for a false positive and a false negative result. And then in contrast to this, indirect AHR testing is something that if you have a positive indirect test, this is very much so highly specific for asthma. And we're going to use that as I kind of move forward and talk about some of the more basic and translational research, is that, you know, this kind of specificity for asthma maybe can provide us a exact phenotype to study these patients who oftentimes don't require controller therapy to kind of understand the early underpinnings and inflammatory signaling that occurs in asthma. But I'll pause right there for questions on the clinical side. All right, well, that's okay. No questions is either is oftentimes a good thing, meaning that things are explained super well, or just sometimes not a good thing, meaning that I'm putting people to sleep. I hope that's not the case. We'll transition now to talk about some of the mechanistic aspects of airway hyperresponsiveness. So we already talked a little bit about this figure I presented earlier in the talk, looking at the differences between mechanisms responsible for direct versus indirect airway hyperresponsiveness. And what we said before is that you know, direct AHR, again, is not specific for asthma. It's a sensitive test, but not specific. And it's really these mechanistic features up here on the upper part of this slide. You know, we're going to focus more specifically on non-allergic drivers of indirect AHR. Everybody at some point with exercise or some other high ventilation exposure will have increased osmolarity to their airway surface liquid, regardless of whether or not you have asthma. But what is it about these central mechanisms that's unique for asthma, and why is it specific for asthma? And so we'll spend some time talking about the bronchial smooth muscle sensitivity and some of the evidence potentially behind that. And then we'll talk about some of the endogenous mediators responsible for indirect AHR. And then I think the most interesting thing is understanding some of the interactions between the epithelium and some of these other inflammatory cell types, specifically the innate immune system, mast cells and eosinophils, and how they play a role in this disease process. So the airway smooth muscle itself, I think that, there's two parts to this. The airway smooth muscle is certainly, there are some slight differences in patients who have asthma. The question is it something really intrinsic to the airway smooth muscle cells themselves? And are they hypercontractile just at baseline? Or is there something extrinsic about patients who have asthma and the underlying inflammatory milieu that's in the airways near the airway smooth muscle bundles that impacts the function? And I think the first question is there something intrinsically different about airway smooth muscle in terms of its contractility? This hasn't always borne out in the literature. There have been some more recent studies of transcriptomics of airway smooth muscle cells that have identified some differentially expressed genes. They can accurately predict an asthmatic patient from a non-asthmatic patient. And there have been similarly some studies looking at airway smooth muscle gene expression of actin and desmin that can associate with the severity of AHR. But again, these are a handful of studies. There really have been many other studies that have not been able to show differences between healthy controls and patients with asthma. And so it's not 100% clear that there's something intrinsically different about the airway smooth muscle cells. I think what's better established is that these extrinsic factors that end up impacting smooth muscle function really is something that does play a role in specific to indirect AHR. And we'll talk here about some inflammatory cytokines, and I kind of piggybacked or cherry picked, I guess, IL-4 and IL-13, of course, of incredible interest is kind of two of the key inflammatory cytokines, active and T2 high asthma. There are several others, TNF alpha being another one that's been studied that when applied in vitro to airway smooth muscle cells will actually increase their sensitivity and response. Did I go? Sorry, I'm looking at the chat room here. I will maybe chat about this maybe just at the end. That's a great question though. There's been some studies also looking at associations between airway hyperresponsiveness and then actually other cell types infiltrating the airway smooth muscle bundle. And of course, this is the classic study by Breitling and colleagues that was then has been repeated since, showing that that there are mast cells that infiltrate the airway smooth muscle in patients with asthma in comparison to controls, and that there can be correlations between this and airway hyperresponsiveness. And then finally, when we'll spend most of our time talking about this in terms of the other endogenous mediators responsible for triggering bronchoconstriction, looking at selected icosanoids and cysteamyl leukotrienes and prostaglandin D2 or PGD2 being really the key bronchoconstricting dysregulated icosanoids in indirect AHR. And if you just expose airway smooth muscle to these mediators, it seems to increase the basal tone of the muscle cells. So it seems that smooth muscle is more sensitive in patients who have indirect AHR, and it's probably because of some of this other inflammatory milieu that's surrounding it rather than the contractility of the muscle itself. So next, looking at some of these mediators, and I think dysregulated icosanoid synthesis is probably the most classically recognized mechanism responsible for driving indirect airway hyperresponsiveness. And just to briefly walk through kind of broad strokes of this pathway, membrane phospholipids require cleavage by a class of enzymes called phospholipases that end up releasing free fatty acids and lysophospholipids that end up serve as the initial substrates for the downstream enzymatic pathways. And of course, we could go through the whole table with minute print of individual enzymatic names, but I think really what you need here for synthesis of icosanoids is really two things. Cleavage of the membrane phospholipids with a phospholipase, and that really serves as the rate limiting step. And then lastly, you need these key terminal synthetic enzymes at the end of the pathway. For cysteamyl leukotrienes, that's lipoxygenases and LTC4 synthase. For PGD2, it's PGD2 synthase. But really, these synthetic enzymes are only expressed and produced by a number of specific cell populations. And within the airways, it's really mast cells that are really the key driver of production of prostaglandin D2. Similarly, cysteine can be produced by several cell types related to, again, production of these terminal synthetic enzymes. But it's really mast cells and eosinophils that are thought to be the key cell types involved in production of these icosanoids. And some studies that have been done by several laboratories, including Thiel's, there have been some studies finding higher levels of cysteine-leukotrienes and PGD2 in patients with indirect AHR in the form of exercise-induced bronchoconstriction. And we've done some studies in the past where we put people on the treadmill, and actually, we've obtained sputum samples before exercise and then exercise them gotten afterward. Both of these icosanoids seem to increase. There are higher baseline levels of these CysLTs compared to healthy controls and compared to patients with asthma but don't have indirect AHR. And then the absolute levels of these icosanoids do correlate with the severity of AHR, meaning the higher levels of cysteine-leukotrienes of PGD2 in your airways end up correlating with the severity of your response to exercise challenge.
Hey, Ryan, when you do that exercise testing, do you have them avoid leukotriene blockers when they're doing it? Is that something that would interfere?
Yeah, so, oh man, you're like a perfect plant here. This is like the next slide here. Wonderful. Yeah, so we do is the preference here. And this is a study actually that Thiel did back in the mid-2000s. And he took these are the same patients who have a washout period that either got placebo and had their exercise challenge test performed. And this is the decline in FEV1 here, or they received a single dose of montelukast and loratadine. And you'll see that there's a significant change in their response to exercise, that there really is improvement in their FEV1 with exercise challenge exposure. And again, this is just a single dose of both these agents. Unclear, again, I would prefer, of course, that the loratadine probably wasn't giving as the antihistamine. We'll talk about potentially why that was utilized in just the next slide. But yes, Drew, to answer your question, we would prefer them to be off leukotriene receptor antagonists because of this effect. And then in the same study, measured cysteine-leukotriene levels following exercise. Again, and these are the same patients who are matched controls here that either got placebo or with treatment. And you'll see that the patients who received treatment with a leukotriene receptor antagonist had reduced levels of cysteine-leukotrienes in their airways following exercise. But also interestingly, there was a non-significant decline in some of these products of mast cell activation. So looking at tryptase, there was a trend towards decline, but it was not significant. But the amount of histamine in the airways itself decreased significantly in patients following exercise who were treated. So it seems that montelukast may be playing some role not only in cysteine-leukotriene downstream mechanisms in terms of receptor binding, but also potentially in mast cell activation upstream. So we talked about some of these media releases, and then I want to spend the rest of the time here talking about the epithelium and its interaction with some of these other inflammatory cell types. And so the background for this, of course, previously Thiel had collected some of this data, and myself and actually Matt Altman and Taha, one of the former fellows of the program, is now at Penn State, have really gone over some of this data that I'll be presenting here in the next couple slides, looking at the location of mast cells and eosinophils either in the submucosal compartment or embedded within the epithelium, and seeing how this correlates with direct AHR, indirect AHR, markers of T2 inflammation, and then crosstalk between, and then maybe understanding how innate cells and the airway epithelium may communicate with each other. So we took a group of adult subjects. They underwent a methacholine challenge test and an exercise challenge test. This is all patients in the study. We obtained sputum from them to classify them as T2 high or T2 low based on a metric called the sputum type 2 gene mean, which is really a metric that's a composite of IL-4, IL-5, and IL-13 expression in the sputum. We obtained endobronchial biopsies from these patients and used a three-dimensional technique called design-based stereology to quantify the exact location or the exact amount and then the exact location of mast cells and eosinophils within the airway. And then lastly, we took epithelial brushings and sent it for RNA sequencing. So healthy controls here were those who had negative methacholine challenge tests, negative clinical history, and negative exercise challenge test. And then patients with asthma were then these patients had positive clinical history, evidence of direct AHR on the Methacholine challenge test, and then were classified as EIB positive or negative based on their exercise challenge test result. And so we'll split this into two halves here, looking at mast cells and eosinophils. So this is looking at mast cells, and down here is the submucosal compartment, up here is the epithelial compartment. And what you'll see is that there are higher numbers of mast cells embedded within the epithelium of patients with asthma compared to healthy controls. And actually, you compare this to in the submucosa, there's actually lower levels of mast cells in the submucosa in asthmatics versus healthy controls. So it seems actually that there's a shift in the location of mast cells from the submucosa to the epithelium in asthma. But if you break these asthmatics down by their EIB status, you'll find that this difference is driven almost entirely by the EIB positive subjects. They're the ones who have the heightened levels of mast cells embedded within the epithelium. Next, looking at eosinophils, a very similar trend is present. You'll see that there are higher numbers of eosinophils embedded within the airway epithelium of asthmatics compared to the controls, although that there are similar levels in the submucosa. Again, breaking this down by EIB status, we see the similar trend. It's really these patients who have indirect AHR in the form of exercise-induced bronchoconstriction. Those are the patients that have higher numbers of eosinophils within the airway wall or within the epithelium. Next, looking at T2 inflammation, so the sputum type 2 gene metric, characterizing patients based as T2 high or T2 low. We find that patients who are T2 high tend to have higher mast cells embedded within the epithelium and lower numbers within the submucosa. There's a slightly different trend in the eosinophils. Again, higher numbers of eosinophils within the epithelium of patients with T2 high asthma, and a trend towards higher numbers also in the submucosa as well. And then lastly, kind of a brief look of some of this kind of unpublished data that I've presented a handful of times, looking at the differential gene expression of the epithelial brushings using RNA sequencing, and then making correlations with simple linear regression between specific genes and increased numbers of mast cells within the epithelium. And so looking at the mast cell specific portion, there we found 18 differentially expressed genes. And some of these genes are not particularly surprising. Again, we were comparing EIB positive versus EIB negative asthmatics. We really wanted to search here for what's really specific and what's unique for exercise-induced bronchoconstriction, indirect AHR. And some of these genes are not surprising. So the IL-1 receptor-like 1 gene, which is the ST2 or IL-33 receptor gene. CPA3 is a classic mast cell gene, of course. And then there are other type 2 genes that are on here too. Periostin, NOS2, and interleukin-1 have been of interest in asthma. Next, looking at eosinophils, and these were a little bit surprising. We found that actually interferon gamma had a significant increase in patients who was found expressed at higher levels in patients who are EIB positive. And this correlated very well with the number of intraepithelial eosinophils. We similarly saw ST2 and CPA3 as being kind of classic T2 genes also being elevated. And then we looked at the IL-18 receptor, which was surprising. There is a connection between interferon gamma and the IL-18 receptor. IL-18, of course, got its fame initially by being the cytokine responsible for triggering interferon gamma production. And we'll talk about how this has kind of made us think about potentially some new directions and ideas to study for inflammatory pathways in asthma. And this is a Ingenuity pathway analysis of the differentially expressed genes in this patient population, comparing the EIB positive to the EIB negative patients. And what we found is that, surprisingly, at the center of this network, interferon gamma, which has a little bit of a controversial role in asthma, people are really not sure what exactly it's doing there, this type 2 interferon. There have been prior severe asthma models that have shown that it's elevated expression in the airways, but how it's functioning mechanistically is unclear. All these patients enrolled in the study were not receiving any controller therapy at all, and so weren't under the influence of corticosteroids or other agents that may have impacted the gene expression profile. So our goal kind of going forward here is going to actually focus a little bit more. My research going forward is really going to be focusing on this IL-18R1 and interferon gamma axis and its role in mild to moderate asthma and indirect AHR. There's a question in the chat from Frank Verant, associations between patients with EIB and increased IL-25, IL-33 activation. Yes, more specifically related to IL-33, that's an area that we focused on more closely. Interleukin-33, we found in our studies is really the key alarmin that's responsible, the epithelial-derived cytokine that's really responsible for triggering and activating mast cells. And we've shown in a lot of these studies, again, that this higher density of mast cells embedded within the epithelium, this is getting a little bit into the weeds, but we've done studies trying to model this, co-culture studies, where we put epithelial cells in the top layer of a transwall plate and then mast cells in the bottom layer. And we find that there can be this kind of feed-forward loop that epithelial-derived IL-33 can trigger mast cells to release IL-33 that then induces further epithelial IL-33 production. So there can be this feed-forward loop that's ongoing. So yes, I think that there is certainly a connection there. I'm not as familiar with the exact data between IL-25. We haven't looked at that as closely because we've been focused on 33, but great question. Okay, so take-home points. Wow, getting up to the bell here. So we talked about this, AHR testing I think can be helpful in diagnosing asthma, but has some important caveats we discussed. Methacholine challenge testing is a sensitive test, but is really most sensitive when we use it in patients who have moderate pretest probability. They're currently having symptoms and they're not on controller therapy. And then indirect AHR is something that's quite specific for asthma. And we talked about some of the ways that it may provide a nice research group to investigate asthma pathogenesis. And then, I think it's, as we said, kind of the focus of some ongoing research and exploring how this intraepithelial compartments, the presence of eosinophils and mast cells embedded within the epithelium, in more studies in the future, kind of better understanding some of the communication between these cell types. I have some acknowledgements here at the end. Of course, chief among them, the components of the Hallstrand laboratory. I stole a lot of studies here from Teal that were done well before my time. Also, the rest of the group over at the Center for Lung Biology, our collaborators over at Benaroya, including Matt Altman, and then also at Seattle Children's Research Institute, Dr. Debley. And with that, I think I will conclude my talk and take some questions.
And I'm just curious, methacholine challenge obviously gives you a lot of information, but logistically can be difficult. And as part of my research as a fellow, it's not the easiest test to do. I did about 20 of them, but how often will you send people for methacholine challenge testing? And are they doing that right now with COVID?
Yeah, so good question. So it's been of some flux. I think the first part of it is how often do I order it? I end up getting, at least at UW is where I have my pulmonary clinic. And I think from talking to the RTs, I think I order about 70 to 80% of the methacholine challenge tests that are done at the University of Washington. And it's mostly just because I get a lot of the asthma referrals. I've kind of cherry picked some of the new patients that I get. And so, but the frequency with which I do it, it depends again on that pretest probability. I'm really doing it on patients that I really don't think have asthma, who have non-specific symptoms, so I can do early in the course. If I do think somebody has asthma, I'll rarely go to methacholine challenge. What I'll usually do is give them a peak expiratory flow rate meter, or try to tell them to come into the lab and organize spirometry when they're very symptomatic, and before I start them on steroids as an acute exacerbation. And then lastly, when are we doing this during COVID? There's been some waxing and waning with it, but now we are doing methacholine challenge during COVID. It's the same thing, that we really have to screen people with getting negative COVID tests before you send somebody over there. But it's something that's back on. There have been some months in the past where we had been holding off when the incidence of SARS-CoV-2 was high in the lab, because of course, repeated spirometry and coughing associated with methacholine exposure certainly can precipitate aerosol generation. But I agree, it's not the easiest of tests, and patients aren't often thrilled when you send them for it. They have to be kind of motivated to, like, hey, we're getting to the answer together, whether or not this is asthma or Question that came up actually earlier in the talk, if I got just a minute here. Yeah. There was a question, Mary Lasley asked about BCD and your differential diagnosis of asthma, but do you also consider Eager syndrome, exercise-associated gastroesophageal reflux, as another possible mechanism for asthma symptoms during exercise? That is an interesting question. No, that is not something that I've previously thought about as a key mechanism. I guess, there certainly would be ways to test that. We obtained BAL samples. We actually bronch people before and after exercise. Certainly could send that for things like pH testing, look for specific gastric enzymes, but I'm not aware of something of that study actually being done. But a great question. Certainly I worry about reflux disease complicating my interpretation of asthma symptoms in general.
All right, anyone else? We're at 8 o'clock. Great talk. Thanks, Ryan, for giving it. We appreciate it.
Yeah, of course.
Yeah. All right, have a good one, everybody.
Great, thanks.
Thanks, Ryan.